Okay, my disclosures are available on the website. Here's our panel. It changed a little bit, so I'm sorry, Luke. But we've got Lutton when he was good looking. Namdari, you were young back then. The hair's better now. Justin, you're wearing the same suit. Awkward. Craig, did you have a professional photographer come in and flex your biceps for that one?
Yeah, and they photoshopped the hair.
I wasn't going to comment. And then, Samir, I don't know how you got on here. You were supposed to be on this panel at one point, and you're surrounded by a bevy of young women, which we wanted to bring up the Internal Affairs Department to discuss. So look, here we go. Let's get into this a little bit. Your typical outpatient rotator cuff repair. This is a 58-year-old male. He had shoulder pain. He had an MRI-confirmed full-thickness tear. You tried to treat him non-operatively for a little while. He's got nothing specific on his past medical history that should concern you, but you should ask about depression and you should ask about opiate consumption, and he's a regular guy. So you go on and you say, okay, well, you're going to have surgery. By show of hands, and actually I want the audience to raise their hands too, who uses, in the preoperative setting, because we're going to start talking about pain from the minute the person enters the ASC, who uses interscalene block? Panelists, just raise your hand. So 2 out of 5 don't use interscalene block. In the audience, who does not use interscalene block? And then other way, who uses interscalene block? So the majority of the audience is using interscalene block. We've got 2 people.
Were you saying just the block or the catheter
Yeah, we use
as well?
catheters.
We use catheters.
So catheters.
Yeah.
So you are gonna have some sort of.
Yeah, I don't do the bait and switch with the block. I'd much rather do the catheter.
Got it. So then catheters. We've got 2 on there. Audience, catheters. Got it. Who uses preoperative Tylenol? Everyone on the panel? Does it matter? Does IVPO matter?
Well, through the anesthesia literature, certainly preloading people with nonsteroidals as well as
So the
Tylenol
question was,
can
do you use
help.
IV Tylenol?
We
or
use
PO
IV
Tylenol?
I don't remember if it's IV or oral.
Okay.
IV Tylenol.
IV Tylenol. Yeah. What about preoperative nonsteroidal? Raise your hand. Panel. Only 1.5. Guys who didn't, Serena, Craig, Luke, why don't you use a preoperative nonsteroidal like a Celebrex?
For me, I don't have a great reason other than patients have some GI issues, so I don't routinely use it.
Craig?
Again, a lot of these things are being done by the anesthesiologist, so I don't prescribe the pre-op NSAID. But
but does your patient get this stuff? Do you even know?
No, they do not get NSAIDs. They'll get the IV Tylenol. They'll get dexamethasone and the interscalene catheter.
Luke, you didn't raise your hand.
All my patients get intraoperative IV Toradol, so I don't give it beforehand.
So they get an NSAID. Yeah. Do you guys give them, and when I'm saying preoperative, I don't mean like days before, the day of surgery, do you guys use any kind of neuromodulating agent? Raise your hand. So, Serena, why yes, why no?
We don't, simply because older patients have had some issues, side effects with gabapentin or Lyrica, so I don't routinely use it.
What's the issue that you think that's there?
They can have some issues with balance, and some can get kind of loopy afterwards, especially if you continue it postoperatively. Preoperatively, it's probably less of an issue if you're only using it for one dose.
Craig, you don't use it?
No, we don't, and I think that's a good point. We don't use it, and it's hard to do the test dose the first day of surgery, especially in those older patients if they have dysphoria or balance issues afterwards. It's hard to learn the day of surgery.
And the reality is that in the anesthesia literature, what it would suggest is that in order to get that calcium channel blocking effect on the dorsal root ganglion, you have to dose them up so much that they are sedated. So it doesn't really work. It'd be great if it did work, but
so I think you all raise important points. Actually, when you do look at the sports medicine literature, and you can look at the ACL and the shoulder literature, both, in most instances, gabapentin is actually a very effective medication in reducing opiate consumption. What's interesting about all these things is that a lot of the time we don't even know what our patient's getting. You know, we would say, oh no steroid for my patient. Well, I would submit to you that your anesthesiologists are going to give everyone 4 milligrams of IV dexamethasone for postoperative nausea and vomiting. So, do you guys know routinely what goes in your interscalene block?
yeah.
Tell me what's in it.
Ropivacaine. For most of my anesthesiologists, they use ropivacaine. Some of them use bupivacaine.
How much volume?
I actually don't know.
Do they put any steroid in it?
Not in the
Do they
reservoir.
put any clonidine in it?
Nope.
So,
It's pure ropivacaine.
Craig, do you know
Yeah,
exactly?
I don't know the volume there, but it is ropivacaine usually. They don't use dexamethasone. I know that some people do, and we do not use clonidine.
Serena, you know your...
Ropivacaine as well. If it's a single shot interscaling block, they do use a steroid additionally because they think it increases the effect.
Yeah. Justin?
Our anesthesia group prepares these, and it has clonidine, dex, and also bupivacaine.
And Luke?
I've started using Exparel, but you also have to put in some of the faster acting. And to be honest with you, I don't know exactly which one they're using right now.
The other thing I would submit to everyone in the audience is that you have 5 or 6 different anesthesiologists who may work with you. They may do it their own way. And then you wonder why some patients get better relief or worse relief. The submission of the point of this slide is that, look, we should be pretty darn consistent. Whichever you do, be consistent. Make sure it's happening all the time. Make sure your anesthesiologists are doing things the same way, at least the same. You want your surgeries to come out pretty well. So this person went, please.
Before we even keep going forward, I think that the discussion needs to be had not in the pre-op area, but actually in your office, and explain to patients that these are not pain-free surgeries. You are going to have discomfort. These are the things that we do to prepare you for that. But if they go into it understanding that they're going to have discomfort, they're much more prepared for that as opposed to feeling like they're going to be pain-free and then afterwards they're sore.
So that's a hugely important point. We're going to come back to that later in this talk. But setting of expectations is going to be very, very important. So this person had a straightforward rotator cuff, single double row repair. You can choose. We can argue about that's not this one. Last night, someone after a couple drinks confided in me that technically, and I'm not going to say who because I want to not, disclose things, but technically he's the best surgeon that ever came out of the Mount Sinai Fellowship. So I don't want to say who said that to me.
That's already known. That's not really a...
But
An accepted fact.
Right, exactly.
Lisa, are you still here? Are there things that you can do as a surgeon intraoperatively to reduce pain? And is there any truth to that? So, Serena, what do you think?
I mean, I think there are. I think surgical speed is probably helpful in reducing the total volume of fluid that goes into the shoulder. And then I do think that violating the deltoid fascia causes, swelling that can go both in the deltoid and down the arm. And there's this concept of compartment syndrome of the deltoid. So I do think those things matter, but how much I couldn't tell you.
Anyone on the panel have something different to add? Is there something that you do intraoperatively that you think makes the procedure less painful?
A fixation technique, you can do tunneling through the greater tuberosity versus anchors, and I do think that there's probably a difference in pain.
And which is more painful?
I think anchors is more painful, especially when you're using a punch and you're punching the bone to its side and sort of impacting that in there. Whereas if you use a drill or a different means of putting it in, I think that's a little less painful. It's almost like causing a fracture.
I've used both. I haven't seen it.
You haven't seen a difference.
How about heat? How about blue use?
Guys, does ablation hurt more or less?
I have no idea.
What about where you put your portals? If you get your portal too high, too close to the deltoid fascia insertion versus more intramuscular, does that help? So any suggestions to this group that, there's nothing you can do in the OR to make your patients hurt less?
I think Serena's point of preserving the deltoid fascia, decreasing your swelling, one of the things that I think you can do is considering doing your decompression after so that you don't have as much swelling. I find that when I do it first, oftentimes I'll get more swelling, and so I think that does make a difference.
So now we're staying on the rotator cuff topic. Is there any role for intraoperative infiltration of soft tissues to do a field block? Guys, can you play this video for me, please? In the back. Maybe. Is there any?
Is this from that landmark article?
Landmark.
Sethi et al.
Is there, so here's a technique, and really Quinn Throckmorton got me into this idea of doing your own blocks, maybe when your anesthesiologist isn't as optimized, or when we initially started using the Exparel, it was not indicated for a nerve block. So giving the patient a suprascapular nerve block on your own, and then coming down around and getting into the axillary. On it, I'm going to shoot you for this one. You've done this, you've experimented with it. What would the indication be, and how effective do you think this is?
The indication is if you don't have someone who can do a good regional anesthetic for you, it's relatively quick. You do it under anesthesia like this, and it takes effect by the time they're awake. especially with your 4 or 5 hour cups, they're totally
Well, it has a no, it has a good role in those patients with COPD or some other, contraindication to having an interscaling catheter. So I think that is perfect for that role.
I think that,
How do you know you're not sticking the needle right into the nerve when you do this?
So, because you took anatomy class, but so the nerve stays about.
No, I mean, the suprascapular nerve block, I mean, there's no way that you know that you're not sticking it right into the nerve. I know it's unlikely, but
So,
I'm just curious.
you're sort of correct, I think. You know the nerve is about 2 centimeters medial
know.
to the.
Thank you.
Medial to the medial aspect of the AC joint. So we did a cadaveric study where we infiltrated with methylene blue, right? And we had no incidence of intraneural blocks. There's another study that came out in shoulder and elbow this month looking at a blind technique. And really, you go down, you stay a little medial, you stay a little rather lateral, and you flood the floor, right? By flooding the floor. So you don't go down, you hit the bone, and then you flood the floor. You don't come back and back it up into the tissue. So I guess you don't know for sure, but if you know your anatomy and you stay a centimeter away, it seems to be a pretty repeatable and safe thing. But it's important there to have, this can either augment your block or it can be an alternative to block, and that's important. There's a lot of people who have real complications. The risks on the panel, who's seen interscaling nerve block complications? Like all of us, right? And those can be some of your worst complications to manage because you know you didn't cause them, and this sort of persistent paresthesia or issue in the hand, it can be very frustrating. All right, so let's go. Please, everyone, open your phone up and let's just do one of these quizzes. So if you didn't already join in. And the question here is, how many opiate pills do you give after rotator cuff surgery? And we'll call them oxycodone 5s or Percocet 5s, right? So as we're going through, panelists, I'm gonna have you guys formulate that number. Before we get into this, what's the major complication after rotator cuff surgery? What's the biggest complication? What do you think, Justin?
Postoperative, in terms of postoperative pain being?
No, just you do a surgery. You say, hey, to the patient, here's the risks, benefits of the surgery. Your chance of infection is such and such. Your chance of not healing is such and such. Your chance of a good result. Re-tear?
I would say
Is re-tear always a complication, though?
It's classified that way.
Because a lot of people they do great not failing to heal or re-torn, right?
Symptomatic re-tear?
Symptomatic re-tear. Okay, so I'll call symptomatic re-tear. What is the symptomatic re-tear rate? Pretty low. Mm-hmm. So Tony Romeo and also a group from the Journal Medical, the JAMA, 20% of patients, when you look at a Pearl Diver base set, 20% of patients after rotator cuff surgery in the United States are still on opiates at 180 days, right? We'd say, no, that's not me, but it has to be someone in this room, right? It can't be nobody. So I would submit to you that our complication rate of rotator cuff surgery, that 20%, that's probably one of the most scary, significant ones. This is defined at 180 days. So we have to, even though our audience here is giving us pretty good numbers, we've got to come up with more consistent guidelines. So how do you learn, or where do you learn to write opiate prescriptions? Let's go down the panel. Where did you guys learn on how many to give for a procedure?
Certainly as a medical student.
You did?
I think here's the challenge. The challenge is we all know that, probably the average number of tablets of oxycodone or something equivalent is somewhere around 25 after a cuff repair that patients take.
So average number, David, 41% of this audience is 30 to 40.
But that's not the question. The question isn't how many pills my answer was not how many pills are you giving. My answer was how many have been taken. The challenge is that patient that requires a little bit more, and we can't give them that prescription over the weekend. We can't give them that prescription in the middle of the night. So that does give you a little bit of a challenge, or at least cause for pause for me. And to be honest, I usually give patients 50 tablets because that way they are not stuck. Because if they do take the medication as prescribed, a 60-tablet bottle is only 5 days.
So David's going to contest that he gives 50. He's got to worry about patient satisfaction, right? We're going to go on to two other topics with this. What is medical diversion? Medical diversion is when you give someone pills appropriately and those unused pills go on to somewhere else, like a high school party or somewhere or a college campus. And that is really an inadvertent pathway to drug abuse. So that is a real source. 311 million pills, opiate pills were written last year that were medically diverted. So I would submit to you that, given too many maybe is part of the problem. The other thing is that, Serena, what do you think the expectation is of a patient? If you give them 50 pills, do you think that affects their expectation?
I think it says to them that they should be expecting to have severe pain that requires that medication. So, I mean, when I started practice, I gave everybody 100 because that's what we did in fellowship. And then over the past 6 years or so, it's come down substantially to 20. So
100 to 20. And so did anyone have formal training in how to write pills for procedure specific? So we asked this question. We asked this question out of a group of skilled surgeons, and they don't. Do any of you teach now in your residency? Do you teach people per procedure how many to give? Sure. You do? So Luke, you teach the residents and your fellows. You're like, look, for a rotator cuff, this is what you give. For this is what you give.
Absolutely, and I think that the more important thing is how long do patients need these things, and it's 3 days. People have 3 days of severe pain after a rotator cuff, and so that's what you need to get them through. After that, they're taking them because they think they need to take them, or they're taking them because they're dependent on them. And you can become dependent on an opiate certainly within 5 days. So, if you give 6 or 50 pills and you take them, 2 every 4 hours for 5 days, there's no doubt you are dependent on them at that point. So I think that you need to provide barriers between the patient having these pills. So I think they do need to call in and ask for more of them rather than, give them too many.
All right, so I'm going to just go each question. David, first question to you. When do you advise your patients to start taking the pills? As soon as they get home, before the block wears off? Are you worried about rebound pain? When do you start?
The following day, because all of my patients in general have an interscaling catheter that typically works for 24 hours, and then so it's usually about 24 hours after their procedure. And they don't necessarily, if they are awake, they don't necessarily need to take a narcotic, but I'm having them take an oral medicine, whether that be Tylenol or Celebrex or something like that.
Craig, how many pills do you give? David gives 50.
50.
You give 50.
50, and I start usually because unfortunately the success rate of the interscaling catheters isn't 100%. Or the blocks. So I'll usually have them start that night, and for the first 24 to 48 hours, try and take it around the clock and try and prevent some of the rebound pain, which you asked about.
Serena, should other oral medications be added and not non-steroidals? The first question to you actually is how many do you give, and then do you use anything else?
I give 20 and Tylenol and Toradol.
So let's talk about Toradol or the non-steroidal. Is anyone worried, or what is it about non-steroidals and cuff healing, and how does that sort of get mitigated in your practice? Panelists, raise your hand if you use the non-steroidal postoperatively. So 3, 4 out of 5. All right, what's the duration you use it for? Just days, tell me.
5.
5 days. So is it safe to use a non-steroidal for 5 days postoperatively and not affect, what if you have a massive tear and you're kind of worried about the tissue?
Doesn't affect my treatment.
Audience, raise your hand in the audience if you use non-steroidal post-rotator cuff surgery. Does anyone have, no, I'll ask. I see him. I'm so surprised by the hair.
He's so sexy.
I was intimidated. Justin, anything else?
How do you know his name?
Griffin, Justin, Virginia. No.
No, but I was going to add in too that I think the point that David brought up earlier about expectations, that really setting the stage for this, and that patients are going to know that in our hands at least, talking with my PA who's here as well, really after 6 weeks they don't expect to get any narcotics from us. But most of my patients after a cuff repair,
after how long?
After 6 weeks, there's sort of a policy that we don't do that. But
so
the
6
reality,
weeks.
Yeah, but the reality is most of our patients are off pain medicines by the post-operative visit for sure. I would say 99% of cases.
All right, so now patient calls in, 12 hours.
Can I take you back on that last question on NSAIDs? Because I think it's really important. This is a great medication for pain relief after surgery. And if you go back to what you started with, the risk is a very theoretical risk that you might have a recurrent cuff tear, but the risk of the narcotic is death. I mean, it is a huge difference. By prescribing a lot of these medications and not prescribing an NSAID, I mean, you're just switching to complication, right? Which is a worse complication.
I think,
Can you comment on the envelope thing?
So I did a study with Mark Lazarus actually recently, and all we did is we gave people a script for oxycodone to go home with, and I put it in a sealed envelope and basically said, break glass in case of emergency. Don't take this unless you have it. But so they had it. We did multimodal, Tylenol, Toradol, CryoCuff, and what we found is actually 70% of people never touched the script. And we counseled them a lot and said, you're going to do fine, you need 3 days, and after 3 days you'll be fine. And what we found is nobody opened the script after 3 days. So really it's 3 days you need to get people through, is what this showed.
yeah, I mean, I think that's what you guys are saying, recurrent things that are all really important. So now they call 12 hours post-op. What do you do now? They're in terrible pain. Do you up their narcotic, or how do you try and address this pain? Anyone? Justin?
I think this is the time where reassurance is really helpful, that this is the period of time that's going to be the most challenging to get through, and just really taking the time to talk with them about this. We actually call all of our patients the first morning after surgery, just to sort of bridge that gap and have the conversation.
All right, David, drug giver. 2 weeks post-op, person's getting better, still a little tired. Hey, can you give me something for sleep? And by the way, I can have some more oxycodone. Do you refill it?
No. So,
What do you
but I could give them a step-down medication, such as tramadol, and that's where I would go down to.
Tramadol is classified as an opiate.
It's still a step down from
Okay.
Percocet. But that's where I'm going to be giving 10 or 20 tablets. I'm not going to be, redosing that.
Raise your hand if you give them a refill. No, oh, there we go. It's more honest people. So, the next question is, raise your hand if you probably didn't know if that patient called to get a refill to your office. Does that happen? PA calls, right? That's a problem, right? That's a problem. And what we do know, again, from Boston's data and the CDC data, is that your risk of becoming addicted, just like Luke alluded to, at 8 days, your risk of being on that medication in a full year is 13.5%. At 30 days of medication, your risk is 30% at the end of the year. And anytime you get, the refills, people who got refills had a 44% chance increase in the risk of them being on this medication in a year. So, I think the answer to refills is going back to what you were talking about earlier, setting expectations. And part of the expectation is that you will not get a refill. I'm really sorry. I know it's going to be rough, but you will not get a refill.
Paul, you also got to make sure your staff or you are checking CRISP database, make sure they're not getting multiple prescriptions from elsewhere too.
So,
we talked about that.
Of the different legislative good things that happen in medicine, many states now have state-mandated programs where you have to go online and check to see that they're not getting refills from other people. Like they call their interns, like, Abood never answers call. Can you just please give me some pain medication? And yes, this is interesting. This is from JBJS 2019 this year, and this came out of New York. Recommended pills for rotator cuff repair, 60, right? So where are we learning this stuff? Like, who's teaching us? This is expert panel consensus, 60 pills. I don't even think that was an option on our discussion, and we're all talking about needing 20 or 25. Josh Dines looked at this again and said, hey, look how many leftover pills we have, right? And in this small series, 36% of their pills went unused. So going back to, how many do you prescribe? I think we have to decide what's the right number of pills. So just down the panel, give it to me again. David, you said 50 afterwards, is what you write. Craig,
Yep, 50.
You said 50. Serena, 20. Justin?
40.
40. Luke?
I don't use oxycodone anymore. I do use tramadol, but I have not found the need for. I think you can level them as strong opioids or weaker opioids, so I don't use strong opioids anymore.
But what do you say to the rest of these guys who are given 50 pills?
Well, the reality is my patients that didn't take them had better pain satisfaction scores. So it's not doing what you think it's doing. The oxycodone, it's not helping their pain. I don't think.
So I think one of the, you guys hear me, this is getting up, it's not fun today.
Give her a mic.
So the two biggest things that changed, and I think Luke and I talked about this, I'm
I'm sorry.
watching. So, because I practice in South Jersey, and my two offices are literally 40 miles apart. So I was in the boat for a long time of writing 50 to 60 pills because I could be at one office and my patient could be 40 miles from the other office, and asking them to come get a script if they really needed more seemed unfair. The two biggest things that have changed for us are, one, we're using interscalene blocks, but with Exparel. So that first 3 days, for most, obviously it's not perfect every time, is really well covered. So we're getting through that hump, so they're needing less. Number two is we now have the ability to electronically prescribe narcs so that I can send it straight from my computer without anybody ever having to get a script. So I can write 10 or 20. And then if I truly get someone who I really believe has the right need for more, I can send it at any time from anywhere, from any office. So that has changed our practice drastically to get rid of those extra opioid pills and just use less with the interscalene blocks. So I will say, I never thought my institution would do the electronic thing, but if you can get that, it makes it a lot easier.
And just to add on that, in the state of Pennsylvania, that's going to become law that we have to, and our practice does already. And as an advocacy person, I would push for all of you to go to your state legislators and make that important, because that is a big deal where we can only prescribe no opioids or very few, and then refill just with a few if you need to.
It's actually so much more convenient. You could do it off your phone, and you're not writing a triplicate or worrying about a late-night phone call or anything like that. All right, so now we're going to move on to, we just talked about cuffs. Let's sort of change it over to total shoulders, right? Because I think that we have a consensus guideline. Let's raise your hand if we can agree that you think 20 pills or 25 pills is enough for a rotator cuff repair. Raise your hand if you don't. Yeah, I would submit to you guys that, trial it for a little bit, see what happens, and see, because we do need to change our behaviors, right? 58-year-old female, straightforward, a lot of arthritis, not a significant medical history, and importantly, we'll get into it. These are not opiate dependent or people with issues before. We're talking about naive patients. Undergoes a straightforward shoulder arthroplasty. You guys critique it or not. Is the goal?
Overstuffing will hurt.
I mean, you would be so lucky if any of your x-rays looked that good, Dr. Murthy. Nettie Hamid wrote an article this year, and he talked about opioid-free arthroplasty, right? And it's a very exciting JSES article this year. As you sort of look under the hood, these were patients who weren't necessarily, they actively recruited themselves into the study, so they're a highly motivated group. So as we get into this, I don't think that the goal necessarily has to be, look how cool I am, look how few I can write, look, I do this opioid-free. The idea is, can we come up with the most appropriate number of pills for the average person? Because it is an inadvertent pathway. So while I'm excited and I love this article, I think that's not necessarily our goal here. Serena, I think you wrote an article about mind games, and all of you guys were leading into expectations. How does the role of setting expectations actually scientifically work out in patients in their opiate use?
Actually, I think Luke can probably comment on this better than I can with his Near Award winning paper.
Thank you. I paid him to say that, actually.
So, Luke.
So setting expectations, we found was a huge game changer for our patients. So we did a prospective randomized study looking at patients with education versus not, but gave them as many narcotics as they wanted. And the people with the education took far fewer, got off them much quicker than those that did not. I will tell you, though, the interesting thing is I did look at this group of patients, of 140 patients 2 years later, and what we found is 11% of our patients became dependent on narcotics. That was with and without. So it's a real big issue for anybody. There's a group of people that if they touch these things, they're going to become dependent on it.
Yeah, Paul, I would also say that to that point that I think one of the important questions is identifying those patients that are going to have a problem. And there was another good paper just looking at, is there a checklist that we can institute in our clinic, for instance, that would identify which patient is at risk for opioid misuse, and then having a really significant conversation with especially those patients.
Yeah, this is, this study up here is looking at ACLs, and it's from John X in Atlanta. And they started out by just giving all their patients 50 pills after ACL. And then they said, you know what, we're just going to, and the patients took on the mean 25 pills. And they said, you know what, we're just going to change it to 30. And when they gave them 30 with no education, patients took 15.6 pills. So just by giving fewer, just by setting that expectation that I was given this many pills, it's going to hurt that much, you reduced it significantly. And then when you added education into it, you can reduce the number of pills down even farther. So Luke, what you're telling people is so important. And setting the expectations occurs, in the office. This is going to hurt. It's going to hurt for a couple days. I'm not going to give you refills, not because I don't like you, not because I'm insensitive, because I actually care about your risk factors. Do you guys get any pushback from this? Do you do this in the office, panelists? Let's go down David, you're handing them out, so.
So am I getting pushback for what?
From patients, when you say, look, I'm only going to give you this many pills, it's going to hurt, or do patients talk to you about this?
Not really. I mean, usually they're pretty understanding. The pushback that I get is from my work comp patients. But that's where, so all of my non-work comp patients get their prescription ahead of time in the office before surgery, so they can go ahead and fill that ahead of time. None of my work comp patients will get that. All of them get the prescription the day of surgery because I've gotten burned several times with the work comp patients taking them all pre-op and having fun. So I do change, I tailor a little bit to, the individual patient.
Craig, any pros on setting expectations or?
No, it's just so important. I mean, you gotta have this candid talk with your patients. These are the problem patients I have where the ACLs, when the mom calls in, my daughter's dying in pain, and talk about pushback, that's where we get the pushback. The cuffs we can handle because they're a little more, they're adults, yeah. But I think that it's important to say you don't have pain for 3 days. By the weekend, it's going to be manageable it should be less than a 4. You can manage that in Tylenol or Motrin or Advil.
Serena, tell me what your multimodal protocol for a total shoulder is.
We use Tylenol preoperatively and an interscaling catheter. And we have an anesthesia team that calls the patients postoperatively to talk to them about their catheter and to potentially increase the rate on it if needed.
Is doing a total shoulder outpatient change anything for you?
No.
Let's go to Exparel. Justin, do you use it? Does it work? Interscalene, field block?
I use a single-shot interscaling nerve block. I do not use Exparel. I think the literature is conflicted on this. Really, when you look at it, Serena and the Routman group had a good study showing that it didn't make a difference. That was JBJS. And then you obviously published a good study showing that it did work. There's a meta-analysis that said no difference. So I think right now, for the increased costs in our hospital system, we do not use it.
Any panelists, anything different on Exparel? Raise your hand, panelists, if you use it.
I use it, and I don't have any data on it, but I do feel like, it gives you that potential to get through those 3 days that you're trying to do, because that's about how long it lasts. So I think that this is something that somebody needs to study and really figure out, though. I think it could be very promising, because I feel anecdotally it works well.
Audience, raise your hand. You use it?
Just a comment. I think it's very important to distinguish whether we're talking about it as a soft tissue infiltrate or in the block. I mean, our studies have shown that it really didn't work for us as a soft tissue infiltrate. It was no better than a single shot block. Patients who actually had an interscaling block plus Exparel used more narcotics than patients who just had an interscaling block. But there are potential advantages if it works as an interscaling block. In an interscaling block, like Katie was talking about, you don't deal with the potential issues of a catheter leaking, it gets blocked. But the only negative potentially is that if they do have a phrenic nerve problem, you can't reverse it, or you can't clamp the catheter or take it out.
Larry, you guys use it at HSS? Do not. Anyone else have any commentary on it? So I think the reality is the jury's out. Anecdotally, I think that it does help. And what I've noticed is the rebound pain that was associated with the standard block does not seem to occur with the longer lasting block. It seems to sort of dull out a little more frequently because that rebound pain was a significant finding.
I agree with Luke that we need to study it because I think in the block it probably works more as it's supposed to work with those liposomal kind of capsules. When we were doing it in soft tissue, a lot of times you're using like an 18-gauge needle, blasting it in there, and that kind of throws off the way that the medicine's supposed to work.
Yeah, I think that's an important point. And the studies, which Justin accurately pointed out, go to both sides of it. You really have to look at the amount used, the dilution, the technique, and it was a drug in its infancy, I think, that we used probably imperfectly initially and are getting better at this.
I agree. Can I just add to that? So interscaling blocks at our hospital, I don't do the outpatient surgeries because the next morning some of them have some rebound pain. Most of them after a day have minimal to no pain, especially after 2 days. But the regular block that morning they have some rebound pain or in the middle of the night. With the Exparel we've been using, I used the soft tissue, didn't seem to make much difference, and we used it in the nerve block from anesthesia. It makes a big difference and it cuts out the rebound pain. And most patients don't have much pain for the first 2 days and not much after that.
Yeah.
So I think it makes a big difference.
Anyone else on this topic? So how many pills, let's go to your phones again. Let's see how many pills we give after shoulder arthroplasty. No. Panelists, let's go. Just down the line. Tell me the number. David, 100, 200?
No, I actually give them all 50, but to be perfectly honest, they don't need it.
50. Craig?
I've been routinely giving them 30, but I got to tell you, I've found that the Exparel interscaling block has really been kind of a game changer with my anesthesia group. Probably a lot of this has to do with how good your anesthesia group is.
Serena?
So we're going to go less.
20.
20. Justin?
Many patients we don't give any when they go home, and I find that it's much less of an issue with than with cuff repair. But for patients that do need it in the hospital, we give 20.
Luke?
Yeah, no strong opioids, only tramadol.
So we have two almost none, and then we have 50 and 30. Audience is going to be mostly between 20 and 30, with 40% of people giving somewhere between 30 and 50 pills. So this is a lot, right? So when I surveyed, I surveyed a group of shoulder surgeons again, and this is about a year old. This is a group who does a lot of shoulder surgery, between 30 and 60. So it really mirrors, behavior patterns mirror the same room. We tried to look at this, and we'll present this year at ASES, and we looked at 3 different centers. So it wasn't just sort of a one-off, right? And at 3 different centers, we found that on the mean, you need about 10 pills, right? So David, you're saying yes to me, but you're like, look, but I write 50. How do you reconcile that?
I can't. I'll probably change my practice. I mean,
Good.
to be perfectly honest, that I think that most of the patients that I have take probably under 10, especially with, we have an indwelling interscaling catheter for 3 days, and to be perfectly honest, they really just don't need it.
Yeah.
So, I learned from you guys, just like hopefully you guys learned from the panel.
Brent?
So Sethi, going back to the slide you had up there before about the give them a refill.
44, yeah.
So do you think it's better to give them 20 or 40 pills even if they only need 10 and absolutely not give them refills? Or is it better to give them 10 and give them potential refills?
So I don't know that
In my opinion, I think there's a better idea to just have a gate there. No refills. When you need a refill, you get the pain management guy. And if you do that, then you probably need to be up at least 20.
So that's you're asking my opinion because the data really wasn't granular enough. It's the Pearl Diver data sets, they don't understand it that well. But I would submit to you that going back to looking at Zerogeny study, you give them less, they take less. It's just a medical fact. So I would set a threshold. I would tell them you don't get any more, and if they come back wanting for more, I don't even send them to pain management. I'm like, you just say, look, I'm doing this because I'm more interested in you. So anyway, 10. I think if there's 2 things you get out of this talk, the number 25 for cuffs, the number 10. And this is what I do for multimodal. There's no doubt, as we quote, how the gabapentin physiologically works. You do have to dose it up higher, but we found, with and without this, we looked at this. 1 pill at night, yes, an older person could get a little tired. I want them to sleep at night. And we only do it for 5 nights, and this has been really, pretty straightforward. And we did this at all 3 centers, and that's how we were consistent on coming to that number 10. So whether you use Exparel or not, I don't know that fully matters in this total shoulder group, and that's just going to be, depending upon what your hospital allows. The last point, and I'm going to strive to stay on time, is do you guys have any discussion with disposal of excess medication? Raise your hand. Raise your hand in the audience if you talk about that at all. Right? That's just an important thing. You're not supposed to flush it down the toilet. I wonder if something we should do is give them disposable bags or something like that, or disposable crush-up kits. Joe?
We actually were doing a lot of opioid studies in our practice, and one of the studies that our foot and ankle colleagues were running required the patient to bring the pills back in so we could count them. What we found is some of our staff were taking the pills.
When you say staff, do you mean Serena?
Perhaps.
So, look,
You gotta be careful when you're doing the
the
study.
point is danger is everywhere.
Yeah.
Right? So guys, panelists, I'm going to ask you, thank you. I'd like, we got 3 minutes left. Give me 30 seconds of each, or 20 seconds each, of what your final thoughts on this are. Let's start at Luke and work over.
All right, so I just throw this at you guys. Our bodies are designed, it's a biofeedback loop. We have pain and we have endogenous opioids called enkephalin that we naturally produce. And if you take an opioid, you stop that biofeedback loop. So you need to consider the idea that you're probably delaying your person's pain recovery by giving an opioid.
Yeah, I think these are all great points. I personally think that there needs to be a role for personalization of some of this in terms of a preoperative checklist, something where we can identify people that are going to have a more challenging time. But I would like to move more towards an opiate-free pain control.
Well, the only thing I would add is that I think there are just going to be some patients that no matter what you do, no matter how much expectation education you provide, and whatever multimodal program you have, they're going to have pain that we just can't control. And identifying those people preoperatively is important because you can let them know that it's going to hurt a lot for them. And I'm even more, I paint a much gloomier picture for that patient so that they understand that maybe this surgery isn't for them.
Do you do a resilience test? Or
We do, well, we have done we did a DRAM test, which is a distress test, and we showed that patients who scored higher on that test were more prone to take opiates postoperatively, and about 20% of our patients having shoulder surgery fell into the depressed category.
Last two guys.
Yeah, set the expectations, and I'm hoping that some follow-up studies will show that my anecdotal experience with the single-shot interscaling with Exparel is actually doing a good job of lessening the likelihood of opioid use.
I think the last thing that I would say is that if you can identify those patients that may be at risk, those patients that are recovering alcoholics, those patients that have problems with narcotics ahead of time, those actually are the perfect patients for an indwelling interscaling catheter because that can be redosed. So I do have, a fair number of patients over the past 10 years who have had those issues where 3 or 4 days after their procedure, they can be redosed with that block. They just refill the reservoir. Those blocks are okay to leave in for 5 to 7 days, and you can truly get them opiate-free and not put them at risk for relapse.
So I'm sorry for sort of a sober talk as the afternoon goes on, but I think it's a relevant talk to each of us. And thank you very much for having us, and panel, thank you.